Hello, everyone. I'm Isabel Ayoub. I'm one of the faculties in the Division of Nephrology at The Ohio State University. I would like to thank the organizers for inviting me to give this talk on new therapies for lupus nephritis. Here are my disclosures. I will review the current recommendations for induction in lupus nephritis, review the outcomes of the current recommendations for induction in LN, and focus mainly on discussing novel therapies for lupus nephritis. I will not be discussing the management of refractory LN or the management of the combination of LN and TMA. And also, I will not be discussing maintenance therapy. So I would like to start with the first recommended guidelines that were published in 2012 on how to manage induction therapy in lupus nephritis. And they suggested back then IV methylprednisolone at 0.5 to 1 gram per day for 1 to 3 days, so up to 3 grams, followed by oral prednisone up to 1 milligram per kilo per day, plus either cyclophosphamide, and they recommended 3 regimens, either the NIH one, 0.5 to 1 gram per meter square monthly for 6 doses, or the EUROLupus regimen, 500 milligrams IV every 2 weeks for 6 doses, or the oral regimen of 1 to 1.5 milligram per kilo per day for 2 to 4 months. Or instead of cyclophosphamide, you can consider mycophenolate at 2 to 3 grams per day for 6 months. Recently, KDIGO published the updated guidelines in 2021. And here the main changes are really lowering the cumulative dose of steroids. So they suggested a lower IV methylprednisolone of 0.75 to 1.5 grams in total instead of 3 grams in total, followed by oral prednisone of 0.5 to 1 milligram per kilo per day. So not much change here. That should be tapered to less than 7.5 milligrams per day by the end of 2 to 4 months. Plus, they recommended either IV cyclophosphamide, the EUROLupus regimen, instead of 3 considered the cyclophosphamide regimen, or the mycophenolate at 2 to 3 grams per day for 6 months. Same for the European guidelines that were updated in 2020. They recommended a pulse of methylprednisolone, but here they were more aggressive at lowering the oral prednisone to 0.3 to 0.5 milligram per kilo per day for 4 weeks, then taper to lower than 7.5 milligram per day by 3 to 6 months, plus either the cyclophosphamide EUROLupus regimen or the MMF 2 to 3 grams per day. And here they added as a treatment option the multi-targeted therapy of adding a calcineurin inhibitor to MMF, especially tacrolimus, for about 6 months. Again, this was not a recommendation, but a treatment option. So not much change between the guidelines that were published in 2012 and 2021. If we look at these recommended guidelines and their outcomes, for example, in the ALMS trial, that compared cyclophosphamide to mycophenolate. The complete response rate at 6 months was 8% in the cyclophosphamide arm and 9% in the mycophenolate arm. And the overall response in both arms was close to 55% at 6 months. So really, the complete response was very minimal at 6 months, and even the overall response, 50% of them did not reach even partial response. Beside the ALMS study, if we look at other different clinical trials and their standard of care arm with placebo, and here I'm not trying to compare different studies, but to have an idea about the 1-year complete renal response rate from using mycophenolate or cyclophosphamide as recommended by the KDIGO guideline. You can see that the percent renal response varies between about 25% to 55% of achieving complete renal response at 1 year. So really, we still have about 50 to 70% of our patients who are not achieving complete response at 1 year of treatment. And why do we care about that? If you look at the data that was published by Chen et al. On the response rate and the kidney survival, you can see that for a follow-up of almost 10 years, 10 to 20 years, patients who achieved complete response, they had 94% kidney survival, compared to 45% kidney survival if they were in partial response, and only 19% of kidney survival in non-responders. So it is very important to try to focus on achieving complete response for better kidney outcomes. And if we look at the decline in end-stage kidney disease over time in developed and developing countries, you can see that there was some decline that started between 1970 and 1980 when we started using cyclophosphamide. And then it plateaued, almost plateaued between 2000 and 2010. And here, close to 2021, we still have about 25% of our patients who progress to end-stage kidney disease at 15 years of age, at 15 years from the diagnosis. So it is still very important to optimize our therapy that will lead to higher response rate and hopefully better kidney survival. Hence, multiple clinical trials were trying to experiment and investigate on different drugs that have different targets, but some of them they failed, some they were terminated. However, there is still hope. If we look at the most recent clinical trials that used Voclosporin or Belimumab, they were positive and they led to FDA approval. So Voclosporin is a small molecule that targets calcineurin and T cells, and the phase 3 was completed. It was positive, and this drug was FDA approved for use in active lupus nephritis. Same for Belimumab, it targets BLyS and B cells. The phase 3 was positive, and it was FDA approved for use in active lupus nephritis. Obinutuzumab is a monoclonal antibody that targets CD20 on B cells. The phase 2 was positive, and the phase 3 is enrolling. So it is showing positive outcome as well. So far, and that's something really new, that we have 2 FDA approved drugs for active lupus nephritis, and hopefully the third is on the way. So again, if we look at the KDIGO 2021, and given these FDA approved medications, the recommendation was still, as I mentioned, first-line therapy is for using mycophenolate or cyclophosphamide, the Euro-Lupus regimen. However, they added the use of calcineurin inhibitor, whether tacrolimus or voclosporin, as an option and a practice point. So it was not a first-line recommended therapy, but it was an option to use in active lupus nephritis. Same for B lymphocyte targeting biologic. They added Belimumab based on the BLyS LN study results as an option and a practice point, but it was not considered as a recommendation for first-line therapy. Of course, they added rituximab as well in refractory cases. So we could just treat everyone with background therapy, whether mycophenolate or cyclophosphamide, plus Belimumab or Voclosporin, since they were recently FDA approved. But which drug should we add? We have no biomarkers to identify who would benefit most from Belimumab or Voclosporin. These new medications do not reduce the immunosuppression burden for lupus nephritis patients. And while adding them to background therapy is safe in the short term, long-term safety data are lacking. Adding on to background therapy increases the pill burden and polypharmacy for patients who already have adherence issues, as we know. These medications are costly, and this may be a barrier for many patients. A significant proportion of patients will respond to background therapy alone. So how to use these medications, it's still not clear. Let's have a deep dive into these trials, and perhaps this will be informative in how to use them. So we'll start with calcineurin inhibitor. The activity of calcineurin inhibitor in lupus nephritis involves two separate mechanisms. The first one is by decreasing the activation and proliferation of T cells and leading to a decreased interleukin-2 transcription and less cytokine release, less tissue damage. Furthermore, it prevents the dephosphorylation of synaptopodin, which promote the stabilization of the podocyte actin cytoskeleton. So one focusing on T cell activation and tissue damage, and the other one is stabilization of the podocyte actin cytoskeleton. And of course, there is the hemodynamic effect that we all know about. Before I talk about the Voclosporin, I would like to mention the first randomized trial using the multi-targeted therapy in comparison to the standard of care therapy that was studied in China. So this is a Chinese cohort. It was a randomized, multi-center, open-label study for induction therapy in LN over 6 months. Every patient received Solimedrol 1.5 grams, then prednisone 0.6 milligrams per kilo per day that was tapered. And the standard of care arm received cyclophosphamide, the NIH regimen. And the study arm, they received tacrolimus at 4 milligrams per day, plus mycophenolate 1 gram per day. The primary endpoint was complete remission at 6 months. And you can see that in the multi-targeted therapy, 46% achieved complete response rate compared to 26% in the cyclophosphamide arm. So definitely superior response in the multi-targeted therapy arm compared to the IV cyclophosphamide arm. The secondary endpoint was overall response. And you can see that in the multi-targeted therapy, it was superior at 86% compared to 63% overall response at 6 months in the cyclophosphamide arm, of course, with statistical significance. Furthermore, the median time to overall response was shorter in the multi-targeted therapy. There was a difference of 4 weeks between the multi-targeted therapy and the cyclophosphamide arm. After this induction trial that was successful and that showed superiority of the multi-targeted therapy, they encourage patients who achieved complete response or partial response to enroll in a maintenance phase trial. 60% of the original cohort who achieved complete response or partial response enrolled in the maintenance phase over 18 months. So there was 6 months of induction therapy and 18 months of maintenance therapy. Those who were on cyclophosphamide NIH regimen, they were switched to azathioprine at 2 milligrams per kilo per day, plus prednisone was lowered to 10 milligrams per day. And those who were on the multi-targeted therapy, tacrolimus was lowered from 4 to 2 to 3 milligrams per day, and the mycophenolate was lowered to 0.5 to 0.75 grams per day, plus prednisone 10. The primary endpoint was the relapse rate, which was almost similar in both groups with no significant, statistical significant difference. But if you look at the complete response, those who were in the cyclophosphamide arm in the induction phase, they caught up with the multi-targeted therapy after 18 months of the maintenance phase. So this is definitely interesting, and we definitely need to understand whether it is still beneficial to achieve faster response in the induction phase, even if after 2 years, both arms will have almost similar complete response rate. So again, the induction phase showed superiority of mycophenolate plus tacrolimus compared to IV cyclophosphamide, but after 18 months of maintenance, both they reached similar response rate. And here also the adverse events were balanced between both groups in terms of serious adverse events, but the azathioprine group had a superior rate of adverse events compared to the multi-targeted therapy with statistical significant difference. What about the voclosporin? Voclosporin is a novel calcineurin inhibitor that developed as a structural change from cyclosporin A, incorporating a single carbon extension with a double bond. Voclosporin has a consistent dose response, potentially eliminating the need for therapeutic drug monitoring, which is very helpful for the patients. And it is 4 times more potent over cyclosporin A. After the success of the phase 2 AURA-LV study in active lupus nephritis, the AURORA 1 phase 3 was initiated. It was a global, double-blind, randomized, multi-center, placebo-controlled phase 3 clinical trial evaluating the efficacy and safety of voclosporin compared to placebo in achieving complete renal response in patients with active lupus nephritis when used in combination with mycophenolate and low-dose steroids. So voclosporin 23.7 milligrams twice a day was compared to placebo on a background of mycophenolate 2 grams and steroid. Everybody was allowed to receive IV methylprednisolone at 0.5 grams per day on day 1 and day 2. And they were started on prednisone 20 to 25 milligrams per day that was tapered down to 2.5 milligrams by week 16. So the novelty in this study was 2 things: the use of a novel calcineurin inhibitor, which is the voclosporin, and the use of a forced aggressive taper of glucocorticoid with a much lower starting dose of prednisone. The primary endpoint was studied at week 52. And after completing the phase 3 AURORA 1 study, there was an extension for 2 years in the AURORA 2 study. So the key inclusion criteria and outcome measures were, of course, patient with diagnosis of SLE that had biopsy-proven active lupus nephritis within 2 years from enrollment. They had to have class 3, 4, or 5 or mixed also. Proteinuria was supposed to be above 1.5 gram per gram and more than 2 gram per gram for class 5. And patient should have eGFR more than 45. The primary outcome was complete renal response at week 52, as we mentioned. And the definition of complete renal response was urine PC ratio less than 0.5, stable kidney function, presence of sustained low-dose steroids, and no rescue medication. Key secondary outcomes were complete renal response at week 24, partial renal response at week 24, week 52, and time to achieving urine PC ratio less than 0.5, or time to 50% reduction in urine PC ratio. Here, if you look at the results of the primary and secondary endpoints, so complete renal response at week 52 for primary endpoint, it was 41% in the voclosporin arm compared to 23% in the control arm with statistical significance. Same for the secondary endpoint, they were superior in the voclosporin arm compared to control and all reached statistical significance. So the complete response at 24 weeks was 32% in the voclosporin arm compared to 20% in the control arm. Partial response at week 24 and 52 were 70% in the voclosporin arm and around 50% in the control arm. Time to achieving urine PC ratio less than 0.5 was shorter, about 169% in the voclosporin arm compared to 372 days in the control arm with statistical significance, and time to reduction about 50% in urine PC ratio was almost a month in the voclosporin arm compared to 63 days in the control arms with statistical significance. So here you see the secondary endpoint, the probability of achieving urine PC ratio less than 0.5 was superior in the voclosporin arm and maintained over time compared to the placebo. Same, the probability of achieving less than of achieving 50% reduction in urine PC ratio was superior in the voclosporin arm compared to control arm. So there was a faster response as seen in the Chinese cohort as well. Faster response by adding calcineurin inhibitor to background therapy, and here with the use of voclosporin, of course. Now, if we look at subgroup analysis, of course, the overall response, as we saw in terms of complete renal response at week 52, which was the primary endpoint, it was favoring voclosporin with statistical significance. And then they did subgroup analysis by sex, age, race, region, ethnicity, biopsy class, MMF use at screening, and MMF dose of less than 2 or more than 2 grams per day. You can see that almost they had a trend favoring voclosporin compared to placebo. However, in white patients, there was a trend favoring voclosporin, but that did not reach a statistical significance. Same for class 5. There was a trend favoring voclosporin, but it did not reach statistical significance. For patients who were treatment naive in terms of MMF use at screening, there was a trend favoring voclosporin, did not reach statistical significance. And those who were on MMF, but they were on a higher dose, more than 2 grams, also did not reach statistical significance. And here we have to be careful on how to interpret subgroup analysis, because sometimes the sample size can be contributing to the non-significance and the comparison. In terms of adverse events, they were balanced in the voclosporin and the placebo. 90% adverse event in the voclosporin compared to 89 in the placebo. Almost similar serious adverse event, mainly infection related, but they were balanced in voclosporin and placebo arm. Same for death. It was less than 1% in voclosporin arm compared to the placebo arm of 3%. So it is safe to use to add voclosporin to MMF in active lupus nephritis. As we mentioned that calcineurin inhibitor in general, they have some hemodynamic effect, and they could be lowering the proteinuria by this hemodynamic effect, masking ongoing active lupus nephritis. So this is definitely a concern with the use of calcineurin inhibitor and with the use of proteinuria as an endpoint with calcineurin inhibitor on board. So here we have some data on repeat biopsies in some patients with remission with improvement in urine PC ratio at 6 months in the multi-targeted therapy using the tacrolimus as an add-on to MMF. And this is from the Chinese cohort that I previously discussed. So 14 patients from the multi-targeted therapy who achieved response agreed for repeat biopsy, and there was 9 patients in the cyclophosphamide arm. And you can see that the activity index in multi-targeted therapy started at almost 12 activity index over 24. And this was dropped to 2 activity index and the repeat biopsy at 6 months. And the chronicity index increased a little bit from 1 to 2. This was in the multi-targeted therapy. Same for the IV cyclophosphamide arm. The activity index dropped from 11 to 3 and chronicity from 1 to 3. So you can see that there is a real objective histological response by adding a calcineurin inhibitor to mycophenolate. There were some repeat biopsies in the voclosporin trials, but the results are not public yet. As I mentioned, the AURORA was for 52 weeks, and there was an extension of 2 more years. So 1 year in AURORA 1, 2 years in AURORA 2. So a total of 3 years of voclosporin use in the phase 3 study. And here, if we look at the GFR, if we are concerned about nephrotoxicity, you can see that the GFR and the placebo compared to the voclosporin arm, they were almost similar. So that suggests that maybe we should not be concerned much about calcineurin inhibitor nephrotoxicity, at least over 3 years of use. However, verifying the lack of nephrotoxicity will need histological confirmation, not just a numerical GFR numbers or creatinine. If we look at proteinuria response over 3 years of voclosporin use, so both arms started around 4 grams per gram urine PC ratio, and the voclosporin arm dropped by 3.3 grams per gram, and the placebo arm dropped by 2.5 gram per gram. So you can see that there is persistent improvement over time, over 3 years period of use of voclosporin and the voclosporin arm compared to the placebo arm. So does that suggest the more use of voclosporin, the better it is? We definitely need to answer this question. And of course, to confirm that there is no significant nephrotoxicity with the benefit of improving proteinuria. So voclosporin, as I mentioned, is FDA approved for active lupus nephritis. How will AURORA change practice guidelines in LN? We don't know yet. When, to whom, and for how long should calcineurin inhibitor be prescribed in LN? That should be answered for sure. Does proteinuria reduction always reflect histological improvement? Are we masking disease by using calcineurin inhibitor in lupus nephritis? Should kidney biopsy be an endpoint, or should we continue to use urine protein creatinine ratio as an endpoint? So should we add kidney biopsy as an endpoint until, of course, we find a non-invasive biomarker that reflect histology and lupus nephritis? Also, we don't know. What happens when we discontinue calcineurin inhibitors? We need this data for sure. With patient, there is definitely concern for relapse in those patients. What about tacrolimus? We know that voclosporin is FDA approved, but how about the use of tacrolimus? We don't have head-to-head comparison between adding tacrolimus versus adding voclosporin to background therapy in lupus nephritis. Moving from T-cell targeted therapy to B-cell targeted strategies, and here I'm going to focus on Belimumab, which is anti-BAFF or BLIS, and obinutuzumab, anti-CD20 monoclonal antibody, and induction therapy for lupus nephritis. So here I'm going to discuss the BLIS LN that led to Belimumab FDA approval in active lupus nephritis. So this was a multi-center randomized double-blind therapy that randomized patient with active lupus nephritis stratified by standard of care and race. And the standard of care was either mycophenolate, those who started on mycophenolate were maintained on mycophenolate, or cyclophosphamide, and they were maintained on azathioprine. And the indication of using mycophenolate or cyclophosphamide was up to the investigator. And the second stratification was by race, Black or non-Black. So you start on standard of care therapy, and then you add Belimumab, and you compare it to placebo. Belimumab 10 milligram per kilo IV every 2 weeks for 3 doses, then every 28 days up to week 100, and the placebo, of course. And the primary outcome was at week 104, and here there was a novel endpoint, which was primary efficacy renal response and not complete renal response. And that primary endpoint was defined as urine PC ratio less than or equal to 0.7, stable eGFR, and no treatment failure. Key secondary endpoint were complete renal response at week 104, time to renal event at week 104. And also key secondary endpoint included the PERR or primary efficacy renal response at week 52. Patient eligible included patient with age more than 18 and active lupus nephritis with urine PC ratio more than 1. And they had to have lupus nephritis that was active, of course, class 3, 4, 5, or mixed. And you can see here that the primary and secondary efficacy endpoint results. So primary endpoint, again, it was PERR or primary efficacy renal response that was superior in the Belimumab 43% versus 32% in the placebo arm with statistical significance. Same for the major secondary endpoint, which was complete renal response at week 104. It was 30% in the Belimumab arm compared to 20% in the placebo arm. And the complete efficacy renal response or PERR at week 52, it was 47% in the Belimumab arm compared to 35% in the placebo arm with statistical significance. So overall, the primary and secondary outcome, they were superior in the Belimumab arm compared to placebo with statistical significance. Here, if you see the response over time, you can see that both arms, the Belimumab in blue and the placebo in black, they separate at week 24. Remember, in the multi-targeted therapy using Voclosporin, they start separating around week 4 or the first month. Here for the Belimumab, it takes 24 weeks to start seeing the separation, but this was maintained over time up to week 104. And the probability of achieving PERR was superior in the Belimumab compared to placebo. Same for complete renal response. It was superior in the Belimumab maintained over time compared to placebo. Probability of achieving complete response was higher in the Belimumab compared to placebo with statistical significance. When we look at subgroup analysis by standard of care induction, whether cyclophosphamide or MMF, and by race, black, non-black, you can see that, of course, in PERR, which is primary efficacy renal response or complete renal response, you can see for PERR, for example, the overall response was favoring Belimumab with significance. However, in the subgroup analysis, if you look at cyclophosphamide, there was a trend favoring Belimumab, but it did not reach significance. In complete renal response, there was really not much benefit of using Belimumab as an add-on to cyclophosphamide. Again, if you are looking at complete renal response at 104 weeks or 2 years. What about black? So there was a trend for PERR without reaching statistical significance. And same for CRR, there was a trend, but did not reach statistical significance compared to non-black. So here, maybe the use of MMF in non-white had a better outcome with statistical significance. But I would like to point again, the effect of the sample size. There were less patients who were on cyclophosphamide. There were less patients who were black in this trial, and that could have affected the significance of the outcome. Furthermore, perhaps those who used cyclophosphamide, they had more severe disease compared to those who were on mycophenolate. We don't know. So that's why we have to be very careful how to interpret subgroup analysis results. In terms of histology, in PERR and CRR, all comers, they had significant superiority for MMF compared to the placebo. However, if we look at class 5, it really did not benefit from using Belimumab for PERR, neither for CRR at week 104. So class 5 might not be beneficial to use Belimumab in class 5. Again, the sample size in the Voclosporin arm and in this study, they were the sample size was smaller in class 5. And we know that pure class 5 is less prevalent compared to proliferative or mixed. What about secondary analysis based on proteinuria, less than 3 grams or 3 grams and above? The overall response was favoring Belimumab with significance at PERR and CRR. However, In terms of PERR, those who had more than 3 grams or higher, really they did not benefit from the use of Belimumab. Same for CRR, there was a trend favoring Belimumab but did not reach significance. So for severe disease, should we use Belimumab? And here I'm defining severe disease by more than 3 grams per gram. Should we use Belimumab? Yes or no, we're not sure, but at least there was no significant signal in terms of complete remission, and there was really no benefit in terms of PERR at week 104. What about relapsing versus new LN? You can see that in the Belimumab arm, the relapsing and new LN, whether in PERR or CRR, they were superior to placebo. However, those who reached significance were only the relapsed, whether in PERR or complete renal response at week 104. So again, for relapsing, there is more benefit of using Belimumab compared to de novo LN. Time to first lupus nephritis flare. The overall response was favoring Belimumab with significance, and you can see that no matter what the background therapy or the class, really they benefit from using Belimumab. So as if Belimumab might be a good maintenance agent as well, because as I showed in the figure, the both arms, they start splitting around 6 months, and this stability is maintained over time. And here we can see that Belimumab decreases risk of flares. So maybe it's a good agent to prevent flare and maintain remission rather than really a good induction agent. Of course, we don't know, these are speculation, but it is important to think about where should we use Belimumab and the induction phase for induction purpose, or to achieve an outcome in the consolidation/maintenance phase. Time to kidney-related event or death, also it was favoring Belimumab all over, but with almost all with statistical significance except in class 5, and here that might be related to the not really beneficial effect on class 5. When we look at the slope of eGFR and the use of Belimumab, you can see that the decline in GFR is less steep in the Belimumab arm compared to the placebo arm, but that did not reach statistical significance. The 30 to 40% decline in GFR between baseline and week 104, you can see that the sustained 30 to 40% decline, there was less decline. If you look at the hazard ratio in the Belimumab arm, whether decline of 30% or decline of 40%. So there is less decline in kidney function with the use of Belimumab compared to placebo with statistical significance. In terms of adverse events, they were balanced in both groups. The treatment-related adverse events were almost similar in the placebo compared to Belimumab. Adverse event related to infection were almost similar. There were also similar death rate in both groups. So the addition of Belimumab to standard of care seemed to be safe compared to placebo as in active lupus nephritis. So Belimumab is FDA approved for active LN. Again, when, to whom, and for how long should Belimumab be prescribed in LN? In the BLISS LN, they gave Belimumab over 2 years period. When decreasing immunosuppression, which should be tapered first, Belimumab or MMF? We saw that Belimumab decreased LN flare. So should we start going down on MMF instead of stopping Belimumab? That we need to better understand and study. Also, whether can we use sub-Q therapy instead of IV? That might be helpful for the patients. And the BLISS LN, they used IV, but in non-renal SLE, they were using also sub-Q. So that's also something that we need to look for. So based on the Voclosporin and the Bliss add-on therapy to standard of care, the updated KDIGO guidelines that were published in 2021, again, they recommended as first-line therapy mycophenolate or urolupus cyclophosphamide. However, they added a practice point as a suggestion, not as a recommendation, but as a suggestion to use calcineurin inhibitor, whether tacrolimus based on the Chinese data or the voclosporin based on the AURORA phase 3 study, or B-cell targeting biologics based on the Bliss-LN study and rituximab for a refractory LN. So again, this was something new compared to the KDIGO 2012, that they added as practice point the use of calcineurin inhibitor or Belimumab as add-on therapy to standard of care. But again, the first-line therapy remains steroid plus MMF or cyclophosphamide. So if we want to think about how to position Voclosporin and Belimumab into LN management, of course, beyond the KDIGO guideline recommendations and practice points, we can think of, for example, starting with proliferative lupus nephritis, because we saw from the subgroup analysis, whether in the Voclosporin study or the Belimumab Bliss-LN study, that these medications did not do very well in class 5, could be again due to sample size. But to facilitate our work, let's assume that our patient has proliferative lupus nephritis. Now the question is it the first time they develop lupus nephritis, or are we dealing with relapsing lupus nephritis? Again, based on the subgroup analysis, those who were treatment naive in the Voclosporin study and those who were de novo LN and the Bliss study, they had a trend favoring the new agent but did not reach significance. So if our patient has a new onset rather than relapsing, maybe we can start with steroid as recommended by KDIGO, and then either add mycophenolate or urolupus cyclophosphamide regimen, plus prednisone taper, of course, and then we can monitor them over 2 to 3 months. And we look for a response in terms of proteinuria. If there is a drop from baseline by 25% or more, then perhaps the patient is responding to our regimen. And if they were started on mycophenolate, we can continue the high dose mycophenolate for 3 more months, then consider reducing the dose to 2 grams or less after a total of 6 months of induction with mycophenolate. If they were on urolupus cyclophosphamide regimen, after 3 months, we can switch to mycophenolate at 2 grams per day. And then we usually continue the mycophenolate maintenance at least for 3 years from the start of the treatment. Now, if they did not seem to improve by 25% or above in terms of proteinuria, of course, assuming that there is stable kidney function, or if they worsen their kidney function, then we should consider adjusting our regimen. If the GFR is more than 45, then we can add to mycophenolate Voclosporin, 23.7 milligrams twice a day. And then we monitor for 2 to 3 months again and see how the proteinuria is doing, if they are, and the kidney function, of course. And if they are improving appropriately as expected, then we can continue with Voclosporin for 1 year based on the AURORA 1, but apparently the AURORA 2 added 2 more years. So who knows, maybe 1 to 3 years, we don't know yet. And the duration of MMF should be again at least 3 years from the start of treatment. Now, if the patient has less than 3 grams per gram of PC ratio of proteinuria, then we can consider Belimumab, because as we saw that Belimumab was not very much effective in those patients who had proteinuria 3 grams or above. So if the proteinuria is not that high, and if the patient is not on a background of cyclophosphamide, because maybe the addition of Belimumab to cyclophosphamide is not beneficial. So we can add Belimumab to mycophenolate and monitor 2 to 3 months. If they are improving, that's great. We can continue Belimumab for 2 years and MMF for at least 3 years from the start of therapy. And if they are not improving, whether we switch to Voclosporin or switch to Belimumab, and despite that, they were not improving, then we should consider whether we're dealing with non-adherence to therapy or we are dealing with a resistant disease. And based on that, of course, we should update our strategy in managing these patients. So this is, again, a consideration on how we can use Voclosporin and Belimumab, but these are not for sure recommendations, whether KDIGO or European guidelines. These are not guidelines, but they are kind of suggestion on how we can use Voclosporin and Belimumab in managing active lupus nephritis. Before we end, I would like to discuss briefly obinutuzumab. Obinutuzumab is a humanized type 2 anti-CD20 monoclonal antibody that was approved for the treatment of CLL and follicular lymphoma. Compared to rituximab, it's a glyco-engineered molecule that has up to 100 times antibody-dependent cytotoxicity. It has a type 2 binding conformation, so it has greater direct cell death. It has reduced internalization, so more access to the OB, and it has less reliance on complement-dependent cytotoxicity. And this is beneficial here because we know there is consumption of complement in active LN. Obinutuzumab results in a greater B-cell depletion than rituximab. So we don't want to be discouraged. We know that the LUNAR failed to show the beneficial effect of rituximab, but here we are dealing with a greater B-cell depleting agent. And obinutuzumab was superior to rituximab in head-to-head trials and B-cell malignancies. So again, I want to stress on the beneficial effect of obinutuzumab in terms of B-cell depletion. Here, when we compare B-cell depletion with the use of obinutuzumab in addition to mycophenolate versus rituximab in addition to mycophenolate in lupus nephritis patients, you can see that there is significant B-cell depletion by week 2 in the OB group, 96% B-cell depletion, compared to 52% B-cell depletion with the use of rituximab. And the B-cell depletion in the OB arm was maintained through week 52. However, the rituximab arm, you can see that there is significant, we start seeing significant B-cell depletion at week 12, and this was not maintained at week 52. So definitely more potent B-cell depletion with the use of obinutuzumab. NOBILITY study was a phase 2 study that looked at the addition of obinutuzumab compared to placebo on a background of mycophenolate and steroid and active lupus nephritis. So they would give obinutuzumab at day 0 and then day 15, or week 0 and week 2. And then after 6 months, they repeat again 1 gram, and then in 2 weeks, another gram. And they follow these patients up, up to week 104. The inclusion criteria here was class 3 or 4 or mixed, but they did not allow pure class 5 lupus nephritis. Your MPC ratio had to be above 1 gram per gram. Exclusion criteria were rapidly progressive glomerulonephritis or eGFR less than 30 or more than 50% glomerular sclerosis on kidney biopsy. Primary endpoints were complete remission at week 52, and some secondary endpoints included overall response, partial or complete response, also at week 52. And here I would like to point out that the pre-specified alpha level of significance was 0.2 and not 0.05. So for the complete renal response at week 52 or primary outcome, it was superior in the OB arm, 35%, compared to 23% in the control arm. And this was maintained at week 76 and even higher at week 104, 41% in the OB arm compared to 23% in the placebo arm with statistical significance. Again, the p-value had to be less than 0.2. In terms of secondary endpoint, the overall response was superior in the OB arm at week 52 compared to placebo, and this was maintained at week 76 and week 104. And you can see over time, both arms, they split at 6 months, like the BLISS LN study. The Belimumab arm separated at 6 months from the placebo. Here also the same. The OB arm separate at 6 months from the placebo arm, and the benefit remains statistically significant over time through week 104. Same for the overall response was superior in the OB arm compared to placebo, maintained over time. B-cell depletion, as I mentioned, there was a significant B-cell depletion in the beginning from week 2. So after the first dose, there was drop by 96% in the B-cell depletion compared to the placebo, and this was maintained through week 52. Safety profile and the group that had OB added to MMF compared to placebo added to MMF, they were balanced really, whether death rate or serious event or serious event related to infections. So obinutuzumab, the addition of obinutuzumab to MMF seemed to be safe in active lupus nephritis compared to placebo plus MMF. So the early and sustained B-cell depletion might lead to a better renal response in lupus nephritis. And that could be the reason why rituximab failed in the LUNAR study, because there was not that much B-cell depletion during the study. So that could be the reason why obinutuzumab is really more beneficial, more potent, with significant outcome from week 52, actually from 6 months of starting treatment through week 102. And because of the positive phase 2 outcomes, an ongoing phase 3 study called the Regency study is enrolling now and will further characterize the profile of obinutuzumab and the treatment of patients with proliferative lupus nephritis. So we have good news, but they are not too good, really. If we look again at the complete renal response at 1 year and the arm that used drug study versus standard of care, for example, in the Voclosporin, 40% complete response at 1 year compared to 22%, Belimumab 30% compared to 20%, obinutuzumab 35% complete response compared to standard of care of 23%. But we are still dealing with low numbers, 30% to 40% complete response at 1 year. So we're still having 60 to 70% of our patients that are not reaching complete renal response at 1 year from starting treatment. So yes, we have FDA approved drugs. Yes, we have positive studies that are going into phase 3, but we still need to improve the response rate to hopefully improve kidney survival in patients with lupus nephritis. And here I would like to mention that we are still trying, we are using different drugs that target different molecules and different pathways, and hopefully they will lead to better renal outcomes at 1 or 2 years from induction phase, and that will help us improve kidney survival in patients with lupus nephritis. And we should down the road be more creative with adding and combining drugs that target different pathways in a precision medicine approach to hopefully improve kidney survival in patients with lupus nephritis. And with that, I would like to thank you for your attendance, and I'm happy to answer any question. Thank you.